All right, hi everyone, and welcome to the Medicaid Insights Colloquium, also known as Mike. Thank you all so much for joining us today. My name is Will Shapiro. I'm an assistant professor in health policy and economics at Cornell, and again, it's great to see all of you in the new year. As usual, I'll start with just a few quick notes for our time together today. So this session will run for about an hour, including 40 minutes of presentation followed by 20 minutes for Q&A. Because there are so many of you with us today, please refrain from using the raise hand function to ask a question. Instead, if you do have a question during the presentation, you can submit it at any time by clicking on the Q&A button at the bottom of your window, and we'll get to as many questions as we can after the presentation. So I want to take a quick moment to recognize the rest of the Mike planning committee for their continued work. That also includes John McConnell from OHSU and my colleague Jamila Mishner here at Cornell. We also want to thank Dr. Sarah Gordon from BU, who is a founding member of this planning group and just rotated off of the committee this year. Now it's my great pleasure to introduce our featured speaker, someone who's a collaborator and friend, Dr. Jacob Wallace. Dr. Wallace is a health economist and associate professor at the Yale School of Public Health. He's also a faculty research fellow at the NBER. His research has analyzed how tools used by managed care influences healthcare utilization and outcomes for vulnerable populations, including how public insurance programs may shape health disparities. He's also studied the limitations of risk adjustment and highlighted the importance of randomization and research. As an aside, I'll also mention Jacob, prior to his career in academia, spent some time working for a state Medicaid agency, and I think his work is a good example of how that sort of on-the-ground knowledge helps to ensure that the work we do in the research community is responsive to the questions that policymakers really need answered to ensure evidence-based policymaking. So I guess for context, I think all of us know that at this point, over 75% of Medicaid enrollees are now enrolled in comprehensive managed care, and in those arrangements, states contract with plans that assume responsibility for providing this public benefit, creating networks, managing utilization, processing claims, providing reimbursement, et cetera. And today, Dr. Wallace will bring us evidence on broadly how managed care manages care. And he'll do that drawing from a natural experiment that randomized Medicaid enrollees to either a fee-for-service program or a managed care program. So please join me in welcoming Dr. Jacob Wallace to the Medicaid Insights Colloquium.
Wonderful. Thank you, Will, for the lovely introduction. You did steal a couple of my intro slides there, but I will allow it. And thank you to the Medicaid Insights Colloquium for having me. I'll just take a moment to share my screen. And hopefully folks can see that, and someone will throw me a thumbs down or shout at me if they cannot. So as Will said, I see my thumbs up. Today's topic is on the private provision of public services. And as Will said, we've contracted out much of the provision of the Medicaid program to competing private plans. And this is a question that has gotten a lot of attention in the literature. Today, I'll be presenting some work that is joint with colleagues here at Yale, including Dan Macambira, who is not at Yale at the moment, but was when he worked on the paper, Anthony Lalo and Chima Ndumale, as well as Mike Geruso at UT Austin. So I think this is the point Will, I think, touched on. In the US, we, not just in Medicaid, but across all of the major sources of public insurance, be it Medicaid, Medicare, or the Affordable Care Act exchanges, rely very heavily on the private provision of social health insurance. And by this, I mean the idea that the government is not directly contracting with and paying providers whenever enrollees seek care, but rather contracting out with private plans that compete for enrollees and receive monthly capitation payments. Those monthly capitation payments, which are designed to cover the cost of both healthcare and the administration of a plan as well as profit, um, those now amount to approximately $1 trillion annually in the US. So we're talking about quite a bit of funding for this model. And Medicaid is where this sort of privatization is most prevalent. About three-quarters, even north of that now, of the Medicaid enrollees are in these private plans. And in Medicare, where folks can select between Medicare Advantage and Medicare fee-for-service or kind of private and public options, about half, or if not more than half, of folks are now in the private managed care plans. So why have we gone down this path? Well, most often the stated reason is related to cost control and the idea that private managed care plans have really strong incentives to control costs. They receive a monthly capitation payment, and their profits are determined by how much more efficiently they can manage care than the fee-for-service program could have. But I think many states have also turned to private health plans in an effort to improve access. Perhaps private health plans can bring new providers into the Medicaid program, or quality private plans have the potential to bring new payment models or new technologies to make care more efficient. So that's the sort of ideal scenario, is we turn to the, kind of competing private plans, and their incentives to control costs help kind of bend the cost curve in the program, and they may have the capacity to drive kind of more efficient care provision as well. So quality and access could potentially improve. But we know from the academic literature on sort of contract theory that the incentives for cost control here can be too strong. If plans can earn profits by stinting on care, or potentially by trying to design benefits that preferentially attract low-cost members or more profitable members, we might actually see quality lower. And so our primary question here is, first, does privatization lower spending? And then at what cost? In other words, what are the trade-offs here? If it does lower spending, are we seeing reduced access or quality in the program? And we're far from the first to study this question. So this question has received a lot of attention, both in the context of Medicare and Medicaid in the US, but also even beyond, sort of thinking about public health plans, thinking about the privatization of hospitals or ambulances. And I'll focus on Medicaid when summarizing the results. I would say the results are generally mixed within the Medicaid context as to whether privatization reduces cost. That's somewhat concerning, given that if you look back through the sort of historical record, in many, many cases, when states describe why they're privatizing the Medicaid program, cost concerns are one of the primary reasons. And when it comes to access and quality, again, we see pretty mixed results. And some studies have found evidence of improvements in access or utilization, and even reductions in sort of disparities. But on the other hand, sort of recent work by Craig Garthwaite and co-authors that study that sort of like mandatory Medicaid managed care rollout in California for people with disabilities found evidence that mortality rates rose when the state privatized the program. One reason why results may be mixed is that, if you know one Medicaid program, you know one Medicaid program. And so, the results from one program's privatization may not generalize to another. States opt for very different models, sort of any willing plan versus like more tight procurement processes. So procurement processes differ a lot. States may also, and states individually and collectively may be learning over time. And so the results of privatization, for states privatizing now may look very different than states that privatized many, many years ago. And a lot of the evidence goes all the way back to some of the privatizations in the 90s. Also, in cases where enrollees can select between the two models, there's sort of what we call endogeneity concerns in economics, which is the idea that the enrollees that select into the sort of private option may be different than those that select into the public option. And particularly if private options tend to restrict access to certain services more or manage the benefit differently, we might worry that different types of enrollees sort between the programs. So this can introduce selection bias. The other literature that is sort of related to today's study is a literature on on sort of broadly, what are the effects of managed care? And there's been a historical focus in this literature on sort of asking at a high level, what does managed care do? And can it constrain spending rather than how does it constrain spending? And I think one of the historical challenges has been that sort of managed care plans do lots of different things. They build provider networks, they operate utilization management, they deploy care management programs. So it's been hard to jigsaw apart uh, what each of those specific mechanisms is doing. And the third literature, which is a little more recent, is this policy interest specifically in denials and prior authorization. So there are a number of, I think, relatively new papers studying both sort of describing the prevalence of claims denials and prior authorization in our various public insurance programs, but also thinking a little bit about the consequences of those for provider participation in our program. So there's a lot of evidence that provider participation in Medicaid may be lower in part because Medicaid programs make it harder to get paid. And part of that is related to claims denials and that sort of process of back and forth between providers and managed care plans or states. There's also some evidence from the Medicare program that utilization management may meaningfully shift the quantity or the composition of drugs that enrollees are utilizing. And that's going to be similar to what we find in our study. This is also important as a just broad policy question because there tends to be a lot of coverage in the popular press and in our, and in various kind of governmental organizations around the use of tools like prior authorization. It's going to be very, very important to understand what trade-offs are associated with these tools in our various public insurance programs. So what does this paper do? I think Will nicely summarized it. So our goal here is to provide some novel evidence on the effects of private versus public provision. And we have a particularly nice setup where both of these models operated contemporaneously and there was randomization between the two. That randomization nicely addresses the endogeneity concern that I described earlier, where if people are choosing which of the two models they want to be in, then we have to worry about selection bias. The other thing we have is we have some really rich data, for example, on claims denials, and that's going to help us try and kind of unwrap the onion of mechanisms in managed care and try and pinpoint specific mechanisms. So our hope is to make progress on the literature. So we're building on many, many great papers and extending them in a couple ways. So more specifically, this is going to be a random assignment. This is a natural experiment where we have 100,000 Medicaid enrollees that were randomly assigned to either private managed care or what is being termed managed fee-for-service in Louisiana, which is similar to a PCCM model, but with a small shared savings component. And we're going to have sort of detailed administrative data, including denied claims, prices paid to providers, and provider network data to really dig into mechanisms. We're going to ask basically three questions. One, does private managed care constrain healthcare spending relative to the sort of PCCM or sort of fee-for-service like model, and for which services? And I want to acknowledge up front, like PCCM and fee-for-service are different. I think most of the literature on how different is PCCM from fee-for-service finds not that much different. But when we come back to the end, maybe we can talk a little bit about some of those distinctions and nuances. The second question we're going to ask is what mechanisms does managed care use to constrain spending? And finally, we're going to ask about the trade-offs for quality and enrollee satisfaction. And just to preview the findings, so we find it kind of at a high level that privatization entails a bit of a cost quality trade-off, but the terms of that trade-off differ by service. So overall, we find spending falls by about 5 to 10 percentage points, depending on exactly which statistical model we use and sort of which follow-up period we look at. And we find very large savings in the pharmacy setting. So about 25 percentage points reduction in pharmacy spending. This is very, very similar to a finding in another paper published in AEJ Applied by David Dranoff and co-authors. So it's nice to see that the result here we're finding in Louisiana is similar to what folks have seen elsewhere, looking at a broader range of states, but without the sort of depth of data, administrative data we have to dig into it. Um, this is not a price story, so this is not about getting lower prices for the same sort of like drug or NDC. In our context, this is really more about quantity substitutions to lower cost alternatives. So think of brand to generic substitutions, for example, as well as reductions in quantity for certain drugs. The trade-off on the medical side is much less clear. There we find much smaller savings and a few, I'd say, signals of potential concern, such as reductions in primary care and more adverse health events, as well as lower enrollee satisfaction. In terms of a mechanism, we identify utilization management, which we can observe a proxy for by seeing claims denials as the sort of key mechanism by which the managed care plans reshape utilization in the pharmacy setting. And so, that result is actually quite consistent with findings in the Medicare Part D program by Zarek Brock Goldberg and co-authors. And I think it's a complement to some of the work by Abe Dunn and co-authors showing that, the managed care bureaucracy has all these costs, which are very real and need to be contended with. It may also, in some settings, have benefits. For example, if it's able to help drive folks from, a brand drug to a lower cost generic. In some cases, within the same molecule, we're seeing substitutions. So in terms of what I want to get through during the talk today, I want to provide just a little background on the setting. Then I want to walk through first this question of whether managed care constrains spending, briefly a second identification strategy, talk about mechanisms, and then trade-offs, and sort of conclude with a bit of a discussion. So because this is, I think, a Medicaid audience, I will go Medicaid friendly audience, I'll go very briefly through this slide. And just to say, the key distinction here between the fee-for-service and managed care models is sort of who's setting up contracts with providers, administering the benefit, and paying the claims. In the case of the private managed care plans, they're receiving a per member per month capitation rate from the state that's risk adjusted, and then they're paying providers and they're building provider networks and doing care coordination and utilization management, et cetera. And the state is paying a kind of fixed risk adjusted payment regardless of how much care is provided. And that's where that profit incentive to reduce costs comes from. On the fee for service side, the state is paying, the state is directly paying providers. There are no kind of network restrictions technically in place, but providers have to accept the Medicaid fee for service rate. And in this particular setting, it is a managed fee for service model where plans are getting basically $10 a month to set up primary care networks and do some basic coordination, but the claims are still paid by the state. So the study leverages a natural experiment that took place in February of 2012 when the state of Louisiana transitioned its delivery model from a state-administered fee-for-service model to two different options: a managed fee-for-service model, like I've just described in the previous slide, and your sort of traditional full-risk Medicaid managed care model. What makes this a nice natural experiment for us to study is that about 2/3 of the enrollees didn't select a plan, and they were randomly assigned between the models. Now, not every assignment was random because the state put in place a bunch of safeguards to keep family members together and try to keep folks connected to their prior provider, which I think make a lot of sense. But we were able to reverse engineer that auto assignment algorithm and isolate the sort of random variation in it. So the other thing about our setting that's going to be nice is we are focused on pre-ACA expansion Louisiana. Now that has some limitations when it comes to generalizability, but it means this population churns less than maybe your traditional Medicaid population. And so what we are able to do is actually build a balanced panel from 1 year prior to random assignment. So that sort of baseline period you see highlighted below from February of 2011 to January 2012. And then our study period is going to run from February 2012 to December 2014. And we're going to build a balance panel that runs that entire length. So there's no kind of concerns here about compositional differences driving any of the results. The other nice feature of our setting when it comes to sort of disentangling mechanisms is that it wasn't until 9 months after the original random assignment that the provision of the pharmacy benefit was carved into managed care. So for the first 9 months after folks were randomized to the sort of managed care and fee for service like models, everyone got their drugs, the pharmacy benefit, directly through the sort of state administered pharmacy benefit. And it was only starting November 2012 that the pharmacy benefit was carved into managed care, and we could see what happened to pharmacy utilization, claims denials, et cetera, at that point. And that's just going to help us sort of disentangle what some of the different mechanisms at play here might have been doing. So very briefly, because this is a pre-ACA Medicaid population, and because we restrict to a balanced panel, this is a very young panel. So the average age is about 9. And we do have some adults in the panel, but it's relatively small. And so spending is also skewed more towards things like outpatient services. So you can see $590 in outpatient spending out of a total of, $1,451, and things like pharmacy. So roughly $400 in pharmacy spending per year, whereas inpatient spending is relatively low. So this would look different if we had a Medicare population. And just to give a sense of common diagnoses in this population, so the 3 most common were ADHD, asthma, and upper respiratory infection. And the most commonly prescribed drugs were ADHD medication, anti-allergics, and antibiotics. I'll go pretty quickly through the econometric details because random assignment makes this relatively straightforward. What we're going to do is basically use a 2-stage least squares model. So assignment isn't binding, i.e. you get randomly assigned to either one of the managed care entities or one of the sort of PCCM or fee-for-service like entities. You can switch. So we're going to use that assignment as an instrument for enrollment in either one of the managed care or PCCM entities. And the only kind of wrinkle is that because the state's algorithm would only assign you to a plan contracted with your prior primary care provider, we have to include fixed effects for enrollees' pre-assignment provider. And you could sort of think of that as the unit of randomization that we need to adjust for. And then we run some specifications with controls and some without, and we show that the results are very similar, as one would expect if our variation is leveraging random assignment. Key identifying assumptions here are, I think, pretty simple and relatively transparent. So the exclusion restriction, so assignment can only really impact the outcomes through its effect on managed care enrollment. We wouldn't want assignment to have some other independent effect on the outcome. And we can test for balance so that, the 2 samples appear balanced, which is what you would expect from random assignment, as well as things like differential attrition. When we build a balanced panel, if it's true that sort of different populations are attriting based on whether they're assigned to managed care or fee-for-service, then when we restrict to a balanced panel and keep only those who stay the entire time, we could introduce sample selection. We don't see any evidence of differential attrition, and I'll spare you that slide, but it's sort of in the paper, which is posted publicly. The other thing is that the sort of validity assumption needs to hold, which is that assignment to MMC impacts enrollment in MMC. So if after assignment everyone just switched immediately to whatever plan they wanted, this wouldn't be a particularly strong instrument. But perhaps unsurprisingly, that's not the case, and we can show you that on the next slide. So this is sort of the first result that I'll show you today. You can orient yourself. So the x-axis is showing quarters relative to treatment. Here, treatment is going to be the start of managed care, i.e. that period at which people were randomized to either the MMC or fee-for-service options. Prior to that, no one was in a full risk managed care plan. So both of the lines are at y equals 0, whereas where y has the share of enrollees in, you can sort of think about the y as the share of folks that are in a managed care plan. Then you can see kind of right after treatment, the group that's assigned to one of the MMC plans jumps up really high. If we had done this monthly, it would go all the way to 100 because for that first month, everyone in that group was assigned to an MMC plan. You could see then that some folks then switch and some of them switch back to fee-for-service plans. So it's not, it doesn't remain at, 90 or close to 100%. And likewise, for those assigned to fee-for-service plans, the line doesn't sort of continue at zero. It floats up a bit as folks switch between the two models. But this is a pretty strong instrument, i.e. there's a very big difference between these groups in their likelihood of being in managed care. We also test for balance, basically ask the question whether the two groups look similar on baseline characteristics, and find that they do. And we look at this across a very wide range of outcomes that I won't share today. So we have this interesting natural experiment. Folks get randomized between the two models. Things appear balanced. We can build this long kind of balanced panel. So the first question we want to ask ourselves is, what happens to spending? And so we're setting ourselves up here for a very straightforward kind of difference in differences model here. And that's what's nice is, the treatment here occurs at only one time. So you can think about that as kind of between t equals -1 and 0 is when folks get assigned to either the managed care or fee-for-service plan. And we're asking here, how much does spending for those in managed care differ from those in fee-for-service before and after the start of managed care? So we're allowing for kind of the effects of managed care to evolve over time. The first thing we can look at is whether there are sort of pre-period effects, and think of those as falsification tests. So if there were some big kind of trends in the pre-period, we might be worried. We don't see anything like that. The other thing we see here is that it's really not until after pharmacy is carved in that the large spending results start to materialize. You see maybe a small kind of spending reduction in that initial period, but things get much larger and almost immediately after the pharmacy carve-in. If we look at this by kind of service, we can see kind of this is roughly overall, this is roughly a 5.6% spending reduction across the entire sort of post random assignment period. But if we limit it to just after the period after pharmacies carved in and sort of after the managed care plans have the full set of tools, it's about an 8% spending reduction. And we can see that almost all of that is coming from a reduction in spending on brand drugs, with a little reduction in spending on outpatient services as well. And just to give you a sense of kind of that's on panel A. On panel B, you can just see the relative share of each of these services. And I guess just an editorial comment here, in other settings, folks have found that one of the things managed care does is it reduces inpatient utilization. And that's one of the ways it reduces spending. In our context, that seems maybe less important and perhaps less of a focus of the plans, given how small inpatient spending is in general for this population. So we don't view this as evidence that managed care plans don't try to or don't have the tools to reduce inpatient utilization. It just seems like it may be less of a focus for this population. The other thing that we can look at is, when do the spending effects materialize? And we can look at this across different services. So panel A shows you that same kind of two-way fixed effects model or difference in differences model just for outpatient spending. And here we see that as soon as managed care starts at sort of t equals 0, we see a reduction in outpatient spending that then sort of persists and maybe shrinks a little towards the end of the period, but persists for about 2 years. Whereas if you look at panel B, which is looking at the effects on pharmacy spending, we see no effect initially. And recall that in periods 0, 1, and 2, pharmacy is still being managed for everyone by the fee-for-service program. So this is somewhat what we would expect. And then after pharmacy gets carved into managed care, we see this very large reduction. And for inpatient, we see almost no effects. I'm going to go very briefly through here in the interest of time, but it's always helpful to have sort of multiple different sources of variation all telling the same story. So one of the sort of additional robustness checks, in a sense, on our results we do is we really run kind of a second study. So at the end of this sort of 3-year study period that was our focus, which was from February 2012 to February 2015, the state actually eliminated the sort of fee-for-service option. And one of the plans exited the market entirely, but the other converted from fee for service to managed care. So we're going to consider that plan the sort of treated plan and ask whether we see similar things in terms of spending reductions and quantity changes for that plan that shifted from the fee for service to the managed care model. And now we'll use the other three plans that were sort of managed care starting in February of 2012 and don't experience any change at February 2015 as our controls. And what we're going to see here is actually very similar set of results to what we found with random assignment. In panel A, you can see the quote transition plan. This is the plan that switches from fee for service to managed care, starts with sort of elevated spending relative to the pooled control plans. Remember, those are the plans that were already managed care plans. And almost immediately following the shift to managed care, spending falls down to an equilibrium level more similar to the other managed care plans. And we see very similarly a very similar pattern for pharmacy spending. And we can also see by squinting at the y-axis that this reduction in pharmacy spending of about $40 accounts for almost the entire reduction in overall spending in the difference in differences context. And we have more kind of results related to the difference in differences design in the paper, but I think for now, I just want to summarize two different sources of identification, two different samples and populations, very similar results in terms of kind of, let's say, an 8 to 12% reduction in spending and a 20 to say 30% reduction in specifically pharmacy spending. So the next question is, how does managed care reduce spending? We have some sense of which services it's reducing spending for, really focused on pharmacy. And so we're going to focus on trying to understand what was the mechanism that drove the reductions in pharmacy spending. So we're going to go back to this Sherry Gleed kind of Handbook of Health Economics chapter from 2000, which hypothesizes a range of mechanisms. One, lower prices. I won't show it today, but we do in the appendix of the paper a very thorough decomposition, including price versus quantity. And we show that prices explain only about 20% of the overall spending effect, and really only on the outpatient setting. So virtually the entire reduction in spending on outpatient services comes from lower prices. And when we dig in, it's actually like lower prices paid for E&M services. But prices explain very, very little of the pharmacy reduction in spending. I should note that rebates complicate matters slightly, and we can come back to that in the discussion. The second potential mechanism is that the managed care plans are building either narrow or potentially smarter provider networks that could either ration care via frictions, i.e. with a narrower network, it's just harder to get care, and that reduces utilization. Or they might steer enrollees to more efficient providers. So you could imagine some primary care providers tend to be more judicious about prescribing generics versus brands. And it's not actually any of the plan's utilization management or prior authorization policies that change the sort of composition of drugs being used. It's actually just that the managed care plans contract with sort of more efficiently prescribing providers. We look at both of these, and I won't go into detail on these analyses, but we basically conclude that neither of these appear to be driving our effects. First, we can attribute members to their primary care provider, and we can include in our model, we can basically saturate our model with fixed effects for all of those providers, which changes our analysis basically to asking whether for members who are being treated by the same primary care provider after random assignment, are there big differences in spending between those in the managed care plan and the fee-for-service plan? If there aren't big differences in spending once we are looking at members all being treated by the same provider, then maybe it is all about kind of differences in steering to providers. But if the spending differences remain large, then there must be another mechanism driving them. And what we find is actually, even after we adjust for these provider fixed effects, our overall spending estimates don't really change. Similarly, we don't find provider network breadth to be a driver of the results. The third hypothesized mechanism in Sherry's paper is this idea that managed care plans could manage care more effectively. So better care management that leads to offsets. This is hard. We don't observe this in our data, so we don't have data on kind of care management specifically, but it's not broadly consistent with the facts. So we don't really find, in our setting, any reduction in inpatient spending or emergency department use. In fact, we find increased avoidable emergency department use. And we also find evidence of reductions in primary care. So I wouldn't say the evidence is sort of dispositive one way or another here, but this doesn't seem to broadly fit the facts. What appears to be the key mechanism in our section is utilization management. So what I'm going to show you next is what we see after the pharmacy benefit gets carved into managed care is this short-term increase or spike in denials for prescriptions just for the enrollees assigned to managed care, with no change occurring to the enrollees in fee for service. And we see that the spending reductions on pharmacy services achieved by the managed care plans tend to be concentrated in the therapeutic classes, so the sort of groupings of drugs that are targeted the most by denials, i.e., where the denial rate is the highest. Very quickly, and I think this is an important distinction between pharmacy and medical denials. In the pharmacy context, we have what's called real-time adjudication, which is when someone goes to fill their script at the pharmacy, if there's a sort of technical backbone that will ping the insurer, and if the insurer refuses to pay because the patient doesn't qualify for the drug for a variety of reasons, then that claim will be denied and the prescription might be substituted for something else, or the person may not be able to pick up the prescription because their provider needs to fill out a prior authorization form, or it may be a non-covered service or whatever. So the drug doesn't actually get picked up. The prescription doesn't get picked up. Whereas on the medical side, denial, sort of claims are submitted, and then the adjudication and denial process occurs after the service is rendered. And that's where you have sort of a back and forth between providers and payers for payment. And so these create sort of very different systems. On the pharmacy side, when you deny a claim, that drug never gets picked up. You don't actually bear the cost of it. So this creates kind of two potential advantages for utilization management in the pharmacy context. The first is when you say no, sort of, but when you deny a claim, like the service never gets performed, or i.e. the drug doesn't get picked up. The other difference is that there's just a clearer set of close substitutes available, i.e. brand versus generic medications, similar molecules, etc. So the sort of third key result I want to share is this spike in denials I described. So here again, now we're looking at months just so we can really see the spike. But again, everything is sort of relative to that treatment period. So that initial start of managed care. And on the y-axis, we just have the share of prescriptions denied. And so for the folks assigned to fee for service, really we just see kind of a secular increase, but no real spike at the time of the pharmacy carve-in. However, for those assigned to managed care, we see this huge spike up in the denial rate that's very short-lived. And then the denial rate for that cohort eventually falls back down to an equilibrium level lower than fee for service. So, okay, we've sort of shown that there's a spike in the denial rate that coincides with the reduction in pharmacy spending. Because if you'll remember when we looked at the timing of the spending effects, the pharmacy spending reduction really occurred right at that same time. But that's, we're sort of econometricians. We want to be really, really careful about trying to establish a causal relationship. And that could be a spurious correlation. So we want to do more to try and build evidence around whether these two things are linked. So the next step is to do a sort of dose response analysis. So what we're going to do is group drugs into therapeutic classes. So you can think antibiotics versus antidepressants, drugs used for diabetes, drugs used for opioid use disorder, et cetera. We're going to then plot estimates of the spending reductions by therapeutic class, leveraging random assignment. And we're going to plot those against the denial rates for that therapeutic class. And we're just going to calculate the denial rate during what you can see over here on the right, we've labeled as the peak period. This is the period in which folks were trying to pick up the prescriptions that they had been prescribed and utilizing under the fee-for-service regime, and encountering the sort of the new managed care utilization management regime. The reason why we don't want to use denials throughout the whole period is that once people shift the drugs they're using, they tend to refill those prescriptions. And so the denial rates fall very quickly for this group. But if the denial rates have fallen because behavior has changed, and thus the denial rates for a given therapeutic class look very low, that doesn't necessarily mean that the managed care regime wasn't particularly strict for that therapeutic class. It's just that folks have adapted to it. That's why we focus on the peak period. We also exclude spending for that period from this analysis to avoid kind of inducing a mechanical effect of if you deny a claim, of course you don't pay for it. We're going to look at denials within that period and then spending throughout the entire post period on drugs, excluding just that window. So let me show you what that looks like. So the y-axis here has our estimates of the effect of managed care on spending now by therapeutic class, estimated using random assignment. And the x-axis has the share of prescriptions denied during that peak period by therapeutic class. And so what we can see here is a downward sloping relationship where the higher the share of prescriptions denied on the x-axis, the larger the spending reduction from assignment to managed care versus fee for service. We also see a sort of grouping of therapeutic classes off to the right, which may be drugs that we tend to think of, or a therapeutic class of drugs where we tend to worry a bit more about overuse, such as antibiotics, expectorants, anti-allergics, agents for dermatitis. And then certain drug classes where we actually see higher spending in managed care, such as diabetes drugs or drugs used in opioid dependence. Nevertheless, we do see a very strong dose-response relationship here. On the next slide, I'm going to show you the same figure, except the y-axis is now going to be the number of paid prescriptions. So you can think about the y-axis now as the quantity of prescriptions. And so what you can see here is as I click to the next figure, you can see that most of the cloud of points has now shifted up to be centered around the 0 line on the y-axis. Meaning, for the most part, what managed care is not doing is reducing the number of paid prescriptions. This is about driving substitutions towards lower cost drugs within those therapeutic classes. The only exception is that side of group of outlier therapeutic classes off to the right, where the denial rates are particularly high and where perhaps overuse is a bit of a concern. For those drugs, we do actually see some reductions in quantity. We can look at this substitution story also in our kind of difference in differences context. So we can see that if I show you quantity of paid prescriptions, and we look at how that evolves over time, starting in panel A, this is sort of overall quantity. So for overall quantity of prescriptions, we see maybe a little disruption right after pharmacy gets carved in, but kind of over the whole period, we don't see a major reduction in overall quantity, but we do see approximately a 1-for-1 substitution from brand, which is reduced, to generic, which increases. And again, here we see maybe some hint of where that disruption is coming from. The brand quantity is sort of falls almost immediately following the new utilization management regime and the pharmacy carve-in, but it does take a little bit of time for the generic paid prescriptions to quantity to increase. And just to give a sense of the potential savings here that are at stake, the average paid amount for a brand drug in our data was $151, and for a generic drug was $38. I'm not gonna walk through this whole figure now, but I'll just say quickly, one of the other mechanisms that appears to be at play is that the managed care plans are just much more likely to deny claims with a day's supply above 30. So the top panel here shows the claim denial rate by the day's supply on the prescription on the x-axis, and you can see the blue line, which is the managed care denial rates, spike up right after 30. And so for any kind of claims with day supply above 30, you can see very high denial rates. So this is one of the mechanisms by which managed care tends to reduce the day's supply on the paid prescriptions. And that's what this figure shows, that another mechanism is about a 10% decline in days supply for the paid prescriptions for brand drugs. Okay, so let's just summarize kind of quickly. We're seeing that managed care generates fairly large spending reductions, 5 to maybe 8%, really driven by in the pharmacy setting, about a 20 to 25% reduction. And there's a few different channels by which they're achieving these pharmacy savings: brand to generic substitution, reduced day supply for prescription, and reduced quantity for some drug classes. So the next thing we wanted to ask was, and I'll speed up a little bit so I can wrap right at 250 for the presentation, was whether this spike in denials and that lower equilibrium denial rate in managed care reflect prescribers learning over time and changing their behavior, or it reflects enrollees facing denials, shifting to new prescriptions, and then just refilling them. And this is important because it's important to understand how these mechanisms impact the behavior of providers. So what we do to think about this question is, well, first we look at basically our original cohort of folks who joined the program approximately a year before the pharmacy carve-in, and we look at the trajectory of the denials they experience. We do the same for a bunch of other cohorts that joined up to and including the sort of month of the pharmacy carve-in. So these cohorts all sort of experience similar trajectories. Now, if providers are learning how the managed care plan utilization management regime works, then as new cohorts join the program, we might expect even their initial denial rates to be lower because the providers, when providers are prescribing for them, they're now prescribing only drugs that comply with the new regime of the managed care companies. That would be what learning might look like here. Unfortunately, what we see when we plot the sort of trajectory for all these new cohorts, so each of these is a successive new cohort of enrollees joining managed care in that particular month and then following them, is that their denial rates start very high generally and then rapidly decline, suggesting that there's not a great deal of evidence that providers are changing their denial patterns, but actually the power of real-time adjudication is you say no, and until the member either gets prior authorization um, or there's a substitution to a different drug, there's no paid prescription. The fee-for-service story is very different. So on the fee-for-service side, we just don't see much of a trajectory one way or another for any of the cohorts on the fee-for-service time side. The other point I'll make before I turn to discussion here is another kind of unique feature of the study is that we can contrast how the public and private models deploy managed care tools, since we can observe claims denials in both. And interestingly, what we see is the sort of therapeutic classes of drugs where the denial rates are high for managed care, in many cases are the therapeutic classes of drugs where denials are low for fee-for-service. So for example, drugs used in opioid dependence, we see a relatively low managed care denial rate and a relatively high fee-for-service denial rate, but that's flipped for antibiotics where we see a relatively low fee-for-service denial rate and a relatively high managed care denial rate. We don't fully understand, I think, what's driving this. But it seems very important to get to the bottom of this to understand how these particular tools are being used. I'm going to skip over section 5 and shift to the discussion. The trade-off section, I'll just maybe briefly voice over to say, we looked at a lot of quality measures, and the results were just mixed. There were a few signals of improvements in the prescribing of high value drugs, but for the most part, we saw reductions in quality, at least as measured by HEDIS measures like primary care utilization or alternative measures like the California Medicaid had developed this avoidable emergency department measure. We also look at a revealed preference measure of enrollee satisfaction. Basically, if you're assigned to a plan, how likely are you to stay in that plan? Here's where we do see meaningful trade-offs. So each of these figures plots the share of folks that remain in their assigned sort of plan. And you can see that the folks who get assigned to the managed care plans are much, much less likely to stay in their plans. But importantly, the difference between the two, i.e. the fact that folks assigned to the managed care plans are just much less likely to want to stay in them, much of that difference materializes before pharmacy is even carved into managed care, suggesting that a lot of the dissatisfaction, at least as measured by this sort of revealed preference measure, is driven by things other than the management of the pharmacy benefit. Okay, I'll just wrap here with like kind of a few high level points. One, we see a cost quality trade-off here when we think about privatization of the Medicaid program. And it really seems to cut along the sort of pharmacy versus medical lines. We also can clearly tie spending reductions to utilization management. So about a 1 percentage point increase in denials at the drug class level was associated with about a almost 2 percentage point decrease in spending in that class. We can also contrast the private and public use of denials where there's some evidence here that private plans may be a little more strategic, either in how they deploy the denials or in the salience of those denials and the extent to which they're changing behavior. So I guess I'll just conclude by saying um, utilization management seems to have potentially both costs and benefits, that maybe denials aren't all bad, and we need to understand them a little bit better and sort of think about when utilization management can be an effective tool for determining who's receiving prescriptions and what the sort of optimal composition of prescriptions might look like. But on the other hand, each of these managed care plans subcontracted to a PBM. So it's not entirely clear that kind of what we've talked about today is a feature entirely of managed care, or rather just um, the results of what a sort of PBM could do, and a state might itself consider contracting directly with the PBM, which I believe is potentially what California is considering doing. So I'll stop there. Happy to take some questions. Sorry, I ran a few minutes over.
No, thanks so much, Jacob. That was awesome. And we have a ton of questions, so I'm gonna dive right in. Um, I guess first, just sort of the broader context of this experiment. Do you have a sense of how common auto assignment is across states? And then I guess relatedly, just to clarify, you're using state-specific claims data here, not TMSIS, and so your ability to do this is a function of detail in those data.
Yeah, so auto assignment is extremely common at the national level. And for those that are interested, if there's like a distribution list, I can share some documentation, Will, with you that could be shared out. But the average auto assignment rate nationally, the last time Kaiser did a kind of exhaustive survey, was about 50%. So, I mean, there's a longer conversation about what does it mean when to have kind of managed competition in markets where there's not actually a lot of choice going on. But to answer the other part of your question, yeah, this is state-specific data, and unfortunately, TMSIS doesn't currently, as far as I know, include an auto assignment indicator. But that would be a really, really impactful thing for the research community if CMS was to include that.
Great, thanks. Another question, I guess, pointing more broadly at generalizability. So with managed fee for service in Louisiana, do you have a sense, like, was that additional PM, was that effective in making PCP networks in Louisiana any stronger? Like, as a function of that, are PCP networks in Louisiana any stronger than in other states?
That's a really good question. I don't have a really detailed answer to that because that tends to be kind of complicated to quantify, like the robustness of the PCP networks. What we found was actually that the managed care plan networks were broader than the fee for service network, even with that sort of enhanced PCCM benefit. And so when we tried to ask whether the managed care plans were reducing spending by having narrower networks, that actually explained less than zero of the effect. In other words, given that broader networks tend to increase spending, it was particularly surprising how much managed care reduced spending because it actually had a broader primary care network. But I do think that from a generalizability perspective, this is a slightly different flavor of fee for service, and that should definitely be kept in mind.
Got it. We have a couple questions about sort of heterogeneity and effects across different groups. So what about whether you saw differences for kids versus adults? For example, this person asked, does prescription drug spending decline more for kids than adults?
Yeah, so we looked at that in the paper and we have some results split out by kids versus adults. Things were qualitatively quite similar. Our adult population of folks who are enrolled continuously for 4 years was so small that we didn't have the precision often to get adult specific estimates. So what I can tell you is the estimates when we pool everyone and the estimates when we just look at the kids are very similar. So I suspect the story among the adults isn't wildly different. But I do think from a generalizability perspective, yeah, it's important to keep in mind this is a relatively young population. Also, this is now a decade old, and we've got, GLP-1s, we've got gene therapies, we have a bunch of new services, often ones that don't have close substitutes available. And so I think some of the substitution patterns and results we're seeing here might not apply to some of the new classes of drugs that I know are very much top of mind for states.
I guess maybe a related question about generalizability. How should folks thinking about generalizing this sort of the broader Medicaid population and in particular sort of sicker Medicaid enrollees?
Yeah, I think that is a limitation. I guess one way to think about it is the nice feature of digging into a mechanism is when you elucidate how a mechanism works, i.e., when you impose utilization management, you can see substitutions across different drugs within a therapeutic class. You can see and understand how real-time adjudication is working. I think that mechanism, because we've kind of shed a light on it, that will generalize, right? We understand that this is a mechanism that operates in pharmacy differently than in medical. But in terms of exactly what spending reduction might we expect it to generate among adults and among a different set of drugs, I think it's a little harder to generalize. I think that's where I lean a little bit. So Zarek Brock Goldberg and co-authors have a paper looking at prior authorization in the Medicare context, and they are finding sort of similarly, it really can drive pretty substantial reductions in spending via changes in quantity. So I think the mechanism is still at play, but yes, always like important to think about the limitations in terms of generalizability.
Thanks. So again, also on this heterogeneity theme, how many managed care plans were operating in Louisiana during this time? And did you see differences in effects across plans to the extent you could estimate plan level effects?
Great question. Very similar question to our editor. So whoever asked it, you're in good company. Yes, there were three sort of full risk managed care plans. The revised version of the paper does actually look for like plan specific effects. In our context, all three were sort of for-profit plans, and we didn't see big differences in the extent of spending reductions across those plans or the sort of quantity effects, or even the sort of revealed preference satisfaction effects. That isn't that different from some of my own prior work that has investigated this question. I find this question extremely interesting. How much variation is there across plans? When I did a study of this with some co-authors, including one who was on this paper, Mike Druso, in the New York Medicaid context, and there we found pretty big differences across plans, but most of those differences were really when you were comparing like the for-profits to sort of non-for-profits. The for-profits themselves tended to cluster and look pretty similar. So that's sort of what we saw here as well.
Cool. We have one question asking about sort of what the denials involve, and are you able to get a sense of whether it's prior auth or step therapy or drugs not being listed on a preferred drug list or something else that was more or less impactful?
Yes. So not at the like individual claim level, the data weren't rich enough to do that, but the plans were required to report the share of drugs subject to things like prior auth, step therapy, et cetera. And so we can show that basically initially following the carve-in of pharmacy, a very high share of drugs were subject to PA, and then that declined over time, which sort of parallels the sort of that spike up in the denials and reduction. So we can paint a picture and like try and understand the potential connection there, but we can't unfortunately look at sort of claim level prior auth data. That is, I think, I know people who are working on that. I think that's a very important like kind of next step in but even better understanding the tools.
Thanks. So we two questions on the pharmacy benefit side of things. So one is, do you know, like in Louisiana, who owns the PBMs that were managing the pharmacy benefit there? And then I guess somewhat relatedly, do you have a sense of sort of how capitation changed when the benefit was carved in?
That is a good question. So the former question, there were each of the plans contracted with a different PBM. So one of the things that we found interesting, and there's some more results in the paper showing just how consistent the reductions in spending are across therapeutic classes, even across the plans, was interesting because there were three different PBMs here, but they all seem to be deploying a fairly similar strategy. One of them was vertically integrated. So we didn't see like big differences between plans that, contracted out to a PBM versus one that had a vertically integrated PBM in terms of what we're seeing. Now, under the hood, in terms of contracting with the PBM and how much the PBM might be capturing of the savings, that we don't have insight into. I think that's a very, very important question. Like, what is the mechanism? What is the contracting mechanism with the PBMs? How should states contract with PBMs if they want to go that route? But we didn't have data on that. The second question, can you remind me what the second question was?
Yeah, so how capitation rates changed once the benefit was carved in.
I don't have that data readily available, although we have, we've looked at the capitation rates for the managed care plans, but I don't think we looked directly at what happened. I mean, so, at a very high level, this is just what I presume would have happened. The rates have to be actuarially sound. When you carve in the drugs, you obviously have to increase the capitation payments to the plans. We know risk adjustment was in place at the time, and we're interested in doing some additional work either in Louisiana or elsewhere, really trying to dig into that question, that sort of risk adjustment question, and like whether some members are predictably profitable versus unprofitable in the Medicaid context, and how that may distort a little bit how plans maybe design benefits or design utilization management strategies or networks. This is, I know, a question that Will, you're also quite interested in, as we've had numerous conversations.
Um, well, unfortunately, that's all the time we have to chat today. Jacob, thanks so much for joining us. That was an incredible talk.
Great.
Um,
Thanks for having me.
So thanks everyone for joining. You should be receiving a 2-question survey about this session to help us continue to make the program better. We'll see you again on April 23rd, when we'll be hearing from Dr. Emma Sando, who's the director of Oregon's Medicaid program and a former deputy director of Medicaid in North Carolina. She'll share how she uses research to drive better outcomes as a state level policy leader. So don't miss that, and you can sign up and RSVP for that session on our website, MedicaidInsightsColloquium.com. Thank you all so much for joining us. Thanks, Jacob, for your fantastic presentation, and have a great day.